Today's series of mini lectures is going to be on substance use and addictive disorders. So we're going to spend, part one is going to be on the pathophysiology of addiction. Is addiction a disease or a moral disorder? Here's a little book by Benjamin Rush, who is trying to address this question. So Dr. Rush considered addiction a disease of the will resulting in loss of control over drinking behavior, incurable only through abstinence. He recommended the creation of sober houses where drunkards could acquire the habit of abstinence. John Goff, a well-known presence on the temperance lecture circuit, called alcoholism a sin, but I also consider it a disease. It is a physical as well as a moral evil. Now, I laugh about this because both Rush and Goff are having that problem of this. Is it a matter of willpower or is it a disease? Rush calls it a disease of the will. Goff calls it a sin, but also a disease. And this struggle exists with every physician, even to this day. So why is there such a thing as addictive disorders? Well, we need something in our brain to push us to go after food, sex, and power in order to survive and have reproductive success and let our genes go on to the next generation. There is a reward center in the brain that provides salience to any kind of activity that results in a selective advantage. And then, as we've discussed in anxiety disorders, the frontal cortex has to mediate the behaviors necessary to obtain the reward or to avoid danger. So, dopamine is the neurotransmitter in the reward system. And you see here the ventral tegmental area sends dopaminergic inputs to the nucleus accumbens. The nucleus accumbens is part of the striatum, and it is considered the seat of the reward center. And there you have, it extends projections to the prefrontal cortex, which has to kind of mediate between various goals and aims that the brain has. So let's look at the nucleus accumbens and dopamine levels at the nucleus accumbens. So you see that there's this spike in dopamine levels as this is a study on rats get food. You see the spike in dopamine levels as the rats get sex, and then pretty much same thing here. Now if you look at drugs of misuse, you see pretty much the same pattern with that spike in dopamine levels as the rodent is about to get or starts getting these drugs. Dopamine receptors are lower in addiction. So on your left, you'll see the nucleus accumbens and D2, it's dopamine 2 receptors. And here on this PET scan, red is lighting up, which means there's a high concentration of dopamine 2 receptors. On your right is the addicted brain, and you see there's very little of that red. So there's decreased D2 receptors in the nucleus accumbens after chronic drug use. And here is the cycle of behavioral addiction. Person has the behavioral traits of vulnerability. They are able to acquire the drugs to self-administer. Initially, they're able to control their drug use. Then it becomes a habit, then they start binging, they lose control, it becomes compulsively used, that point which they have addiction. Then they may try to stop, but they relapse. So this is the behavioral spiral of addiction. We can think of addiction as a hijacked reward system.
Device which trains the animal to turn on the stimulus for himself. Here you notice the animal wandering toward the pedal. When he first touches it, he gets no stimulation. It's not connected yet. Then one time he touches the pedal, it does turn on the stimulation. You can see the lights go on.
Now, the interesting thing about the old stimulation, the rewarding stimulation, was the strength of it. It was somewhat different than rewarding stimulation for food and water in that there was no satiation. Animals would continue for hours and hours and didn't seem to satiate. They didn't feel full. They would just keep doing it for long, long periods of time. They would do it to exhaustion.
Now, I will electrify the grid. The animal must cross an area that gives a very painful shock to the feet in order to get to the pedal and stimulate the brain.
And a rat wanting brain stimulation would brave a shock stronger than even a starving rat would brave to get food.
This shows a rat is willing to pay a very high price in order to get to the pedal.
Human addicts will pay just as high a price for their rewards.
So there we see how a rat will do anything, risk electric shock, stop eating, and eventually die just to continue to stimulate the nucleus accumbens. Now, let's imagine for a moment that you're rummaging underneath your bed. Let's say you're looking for something that you think might be there, and you see this little switch or this little button, call it a button. You're like, what's that? I never saw that. You press the button, and suddenly you have a rush of the best feeling you've ever had in your life. You're like, whoa, this is amazing. You press it again, you get the same feeling. Well, that day you might arrive a little late to work as you continue to press that button. Now, you leave work early, you come back, you go under your bed, you press that button again and again, and you're just amazed. You may start giving up social events, as going under your bed and pressing that button is far more pleasurable than being social. Now let's start saying that now you have to start pressing that button 5 to 10 times before you get that rush. So now you're going to start arriving at events late. People are going to ask you, well, what did you do last night? And you might be a little embarrassed to say you were under your bed pressing a button 20 times. So you're going to start making excuses or going to lie about what you're doing. Now, let's say you get fired because you're just not going to work anymore. You might have to steal to get enough money to pay your rent so that you can actually keep pressing that button, or steal for food. After a while, job, food, money relationships become secondary. All you care about is that button, and now you have to press it 50 times to get that feeling, 100 times to get that feeling, etc. You're just going to be focused on that button. So that's kind of what happens. If you have a button to just stimulate the nucleus accumbens, that's exactly what's going to happen to you. Now, as we look at the areas in the brain that regulate the reward system, you have here the limbic system, hippocampus, amygdala, memory of the drug or the reward, feeds into the nucleus accumbens, which is the reward area in the brain. And there you get the reward, the salience. Then you've got the orbital frontal cortex, which is leading the drive. It kind of leads the brain to actually go and get what you want. And here's the regulation of the prefrontal cortex and the anterior cingulate gyrus that are responsible for inhibitory control. So looking at it like this, you've got the memory reminding you about the salience and the reward that you had when you used the drug. It's sending information to the frontal cortex, say, hey, you really ought to consider this. This is really great. You know, you should drive the brain towards going and getting it. But this part of the brain, the prefrontal cortex, then exhibits inhibition on the drive. So if the frontal cortex is strong enough, it says, look, I see what you're saying here, but we've got more important things to do, so we're actually not going to use drugs and we're going to survive. But if the control area is too weak and it's unable to inhibit the signals of these systems, you actually go use the drug, which certainly can lead to death, as we'll talk about momentarily. So we think of addiction. Why do some people get addicted and others not? Well, there's the biological basis where there's clearly a genetic risk. Gender, males greater than female, and people with other psychiatric disorders also have a biological predisposition to use drugs. Then you've got the environment. A person grows up in a chaotic home. If the parent uses, if peers use, what the attitude of the community is toward drug use, and then poor school achievement can also lead to drug use. So here the individual uses the drug, various routes of administration, what the effect is of the drug. On some people, cocaine just doesn't light up that nucleus accumbens, and other people it does. The earlier in someone's life that they use, the higher the risk of addiction. Certainly cost and availability are issues. Then we have the brain mechanisms we just discussed, and the outcome could be addiction if the orbital frontal cortex does not, it's the prefrontal cortex does not exert inhibitory control. Okay, so let's talk about the definition and screening of addictive disorders. So definition, it's a pattern of self-administration with overwhelming involvement with the use of a drug, getting it, and a high tendency to relapse if one is in withdrawal. In other words, if one stops using the drug. And this behavior continues even when there are negative consequences for the individual. Now, I have to talk about changes in DSM-5 because all of the attendings and many of the residents you've worked with have grown up in DSM-4. They're going to be using substance abuse and substance dependence instead of the new term substance use disorder. You know, part of this is a politically correct change. Instead of substance abuse does sound pejorative, and we view this as another medical disorder. We don't call Crohn's disease a gastrointestinal abuse, so why are we calling that substance? So we call it now substance use disorders. Another change is that in the DSM-4, addictive behaviors that, like gambling, were not considered addictive. Now we've taken things like gambling and put them in addictive disorders. Also, my own preference is never to ask questions about illegal drugs, but to talk about recreational drugs because of the decreased stigma associated with the phrase recreational versus illegal. So DSM-4 via DSM-5 criteria, I don't really need you to know the DSM-4 on this. But I do want you to take a look at the DSM-5 substance use disorders and look at all the criteria right here on your left. So the first part is consequences. So a person uses a drug in hazardous situations, i.e. driving. There's social and interpersonal problems related to use, that's a consequence. Neglecting major roles like parenting, employment, etc., and having legal problems. Down on the bottom here, further consequences. There are physical or psychological consequences related to use, and then activities that are given up to use. Then you have some physiologic changes. The person stops the drug, they get withdrawal. Tolerance is when they need more and more of the drug to achieve, either to get high or even to just feel that they're no longer withdrawing. So that's the physiological change. And over here you have a lack of control. The drug is hijacking the brain. The individual loses their control over the drug. So using larger amounts than what was expected, repeated attempts to control or to quit, spending a lot of time using, and craving a drug. So the drug has overcome the brain and the person loses control. Now, if you look at these criteria, 2 to 3 symptoms means that you have a mild substance use disorder. Moderate, which is presence of 4 or 5, refers to a moderate use disorder. And severe is the presence of 6 or more symptoms. And you can see that makes sense. But all you need is 2 or more to be considered having a substance use disorder. Now, we know, or you know, the CAGE questionnaire. And this maps entirely to what I was, how the categories I was giving to the definition of a substance use disorder. First, there's loss of control. Individual, have you ever tried to cut down? If the patient says yes, it shows that they've been trying to control the drug, but the drug's been controlling them. Consequences. Have you ever been annoyed by someone commenting on your drug use? Have you ever felt guilty about your drug use or something that you've done while you've been intoxicated or looking for drugs? Those are consequences, social consequences. Withdrawal and tolerance refers to needing to take a drug or alcohol in the morning to offset the withdrawal that may occur the following day. So you've got loss of control, you've got consequences, and you've got physiologic changes in the brain. So when I am assessing a patient, for example, who's using marijuana, my main focus is loss of control and consequences, since there's not entirely a clear withdrawal or tolerance. In fact, with marijuana, there can be reverse tolerance where a person just needs a little bit, a little hit, one hit is enough to get high. In the case of consequences, there can be academic consequences, which I see a lot in young adults who are smoking pot. There can be legal consequences, getting in trouble, getting kicked out of school, interpersonal problems, financial problems, health problems, and then spiritual or existential problems. So for marijuana, for example, I had a 45-year-old homemaker, a woman, who was smoking marijuana all day while she was home doing chores. And there were really no consequences for her on any of these other fronts. The problem is that she was a devout Catholic, and she viewed her marijuana use as being non-Catholic. And so that caused a spiritual problem from her, which she then sought help for. An example of an existential consequence, although this is not about drug use per se, is that a CEO of a very large company took senior executives to Las Vegas for a weekend. And while there, they all drank and gambled, and they also used, they were all men, and they also hired sex workers. And he had a sex worker come to his room in the hotel, and she gave him oral sex. So he came home really devastated. He was a family man. He prided himself on being faithful to his wife, a good father, etc. And here he had done something that he felt was really stupid and threatened his sense of who he is. He had none of the other consequences at this point, but he came in because what he had done challenged his very notion, his very identity, notion of himself. All right, so I'm lazy and I don't like to have to go through a whole CAGE questionnaire. So fortunately, there's one question you need in order to screen people, which is, over the last year, has there been any time you've had 5 or more drinks for a man or 4 or more drinks on a single occasion? And you got to memorize this, by the way. In addition to CAGE, this question has to be memorized. If a person can remember in the last year particularly, then it's a positive screen, which means that then you have to do a CAGE, and then you can look into a whole range of consequences that we discussed, and of course then look at the DSM criteria and see if they meet 2 or more. So the safe drinking limits are considered less than 5 drinks for a man on any single occasion, and no more than 14 drinks per week. For women, less than 4 drinks on any single occasion, and no more than 7 drinks per week. Anything more than this is considered high-risk drinking, and follow up with this with the CAGE, as I mentioned, and assess consequences. Now, are we discriminating against women to say that they can't have more than 3 drinks? No, the alcohol dehydrogenase is the enzyme in the gut that metabolizes alcohol. Women have lower levels of alcohol dehydrogenase in their stomach. Therefore, the amount of alcohol they absorb per drink is going to be higher. So women will have the same blood levels with 4 drinks as a man will with 5 drinks. How to screen for drugs. So I ask, have you used ideally you use these separately. Have you ever used recreational drugs for pleasure? Have you ever used over-the-counter drugs for pleasure? And have you ever used prescription medications for non-medicinal purposes? So this would be a screen, and then if they say yes, then you have to follow up for further screening and look for controlled consequences and the physiologic changes associated with many drugs. And again, these are the consequences that I look for when I'm assessing whether somebody has a substance use problem. Well, here we have Prince, who died, I think it was 2 years ago now, from an opiate overdose. So you may have heard that we have an opiate crisis in this country right now. 64,000 overdose deaths in 2016, and you can see the huge rise in primarily, this is driven by opiate overdose deaths, if you add all of these. And at the top are synthetic opiates like fentanyl that's driving most of the overdose deaths, and that's what we think Prince overdosed on. Here just looks at the overdose rates through the years, and you can see how this is just climbing precipitously. So the president this year declared there'd be an opiate epidemic, an opiate emergency, that there's, a lot of experts coming in to try to see what can we do to lower these deaths. Note, a lot of these deaths are probably suicide and misclassified as drug overdose. So 60% of the drug overdose, or the death to drug overdose, are due to opiates. This has quadrupled since 2000. 7,000 patients are treated each day in emergency rooms for substance-related problems. And note that we're the only legal providers of addicted drugs, so it's really important for us to judiciously prescribe opiates and other drugs and avoid excessive prescriptions. Well, what are the clues? Now, you really should be screening every patient for these disorders, but patients lie. And I want to say something very important, which is lying is not a matter of the person being a bad person. Lying is a symptom of addiction, just like dyspnea on exertion is a symptom of congestive heart failure. It's not the person's fault because the drug has hijacked the brain. The person does not, once they're in the cycle of addiction, they don't want to lie, but the drug makes them lie. Remember, the drug goes directly to the nucleus accumbens, and higher brain centers are helpless in stopping the drive to pursue that drug. So let's say you miss that the person has a substance problem. What ways are you going to detect that this person may have a disease of addiction? Well, this is going to be a patient who frequently misses appointments, patient who may not adhere to the advice that they're provided. Their illness may be poorly controlled. They're notorious for calling on Friday night saying they ran out of their Vicodin, for example. The patient comes in, they can be very demanding about wanting opiates. Doc, nothing else helps my pain other than these Norco. I know my body. How could you let me go in pain? This is completely unfair. You're heartless. And physicians, generally we like to be nice people. We want our patients to be happy. And these patients can really press your buttons and almost make you give in and just prescribe them because you don't want them to be angry and because they can convince you that, nothing else does help the pain. What are you going to do? Like, they've got to go to a wedding on the weekend, and how are they going to go if they're in such severe pain? Also in medical practice, patients can feign or exaggerating illnesses, such as back pain, for example, to get opiates. And of course, one of my favorite words is lying despite the evidence. You get somebody comes into the ER and it's documented they've been there before and they've had cocaine in their urine and they've been labeled, there's a diagnosis in the chart, cocaine use disorder. Patient comes in for, say, chest pain, and you ask the patient, gee, I see that you've been here before, and you're using cocaine. When was the last time you used cocaine? Oh, no, doc, I gave that up, 10 months ago. I'm clean, doc. Well, you get the urine tox screen, and there's the cocaine in it. And you're wondering, why didn't this person know? Yeah, they knew because they gave the urine sample. But lying is just a symptom of this disease. And it can be hilarious that a person says, no, I don't do any drugs, or I gave that up, and still the urine is positive. Okay, let's talk about psychological interventions in substance use disorders. And the main method that you should all know is motivational interviewing, and I know you have seminars on this and also practice. Very powerful motivator to get people to change. Now, motivational interviewing is intimately connected to the stages of change, and I'm assuming that all of you are kind of aware of what these stages mean, and if not, here's just a refresher. You can read this on your own. So what is motivational interviewing? It uses the Socratic method. The physician does not give advice, but asks questions to the patient, leading the patient to conclude what the physician knows is the better route for that patient. If the patient espouses change, then you've motivated them. They don't need you to give them advice because frankly there are plenty of people in their families that are giving them advice. What's little left of their the orbital frontal cortex is, actually it's the prefrontal cortex, I'm constantly getting that confused, but with the prefrontal cortex is also telling the brain, hey, you got to stop this, but it's weak. So one of the best things to do is the patient if you talk about the addictive disorder, kind of repeat, enumerate, and clarify, and frame what the patient says. So I always start out with, well, tell me, what do you like about cocaine? And patient's really surprised because everybody's been wanting to strangle them, and you're like starting with, what do you like about it? Well, I like the way it makes me feel. I like it when I'm high on cocaine, I can really enjoy sex. It's like all of my friends use cocaine, and we have a great time, and I look forward to it through the whole week, and and on Friday I just get so excited. Okay, so what you're telling me you like about cocaine is you like the way it makes you feel. It gives you something to look forward during the work week, and it's a social factor in your life. Is there any other things that you like? And so the patient keeps telling you, you say, is there anything else? Is there anything else? And then finally you repeat everything that they say, and then you go, well, what don't you like about cocaine? And kind of the same issue. And hopefully as you do this, the balance of not liking, the cons of drug use end up weighing heavier than the pros. And you then can create cognitive dissonance by saying, on the one hand, you tell me you like cocaine because of this, this, and this. On the other hand, you don't like cocaine because it renders you useless the following day. You feel depressed and even suicidal. You don't want to go out you don't want to do anything on Saturday because you binged on Friday night. And you go on and on. So patient who's in pre-contemplation, the physician just needs to raise awareness of the problem. You don't need to score a goal. You're just trying to get them to the next stage. In contemplation, you want to tip the scale. In preparation, you want to increase the likelihood that they're actually going to go and do it. Then action, and then you want to prepare them for possible relapse and maintenance. So in pre-contemplation, if the person comes in with a drug-related complaint, it's very easy saying, hey, I wonder how what do you think about alcohol might be relating to these palpitations? And you let the patient say, oh, is that possible? I didn't even know that. You can also say, what does your significant other say about your smoking of marijuana? And that kind of is about the interpersonal consequences. Often the patient will think it's no problem, but if you ask what the people around them have to say, then just by them enunciating what their significant other says, they're saying it. And so that takes them one more step to realizing they may have a problem. And then if you're going to give advice or you're going to give them information, it's always important to say, is it okay if I give you information? Because once they say yes, then, well, they're going to be more open to the information you give them. So the important thing is don't let the patient leave the room without making them agree to do something. So would you be willing to track your alcohol use over the next month? How many days do you use 5 or more drinks? And how would you go about tracking it? Again, you need something concrete. It can't just be a thought experiment because the addicted brain is not going to do thought experiments. It's going to need a concrete action. And are there any steps you can take today to avoid driving or placing yourself in risky situations while using? This is really important to ask the first time because obviously that's dangerous and could kill the patient as well as someone else. So we talked about the pros and cons, promoting ambivalence, and creating discrepancy. You know, the discrepancy or cognitive dissonance is a lot of fun. I'm a little confused. You said that alcohol quiets your mind, but now you're telling me that you're more anxious the next day. And you throw the hot potato in the patient's lap, and they have to kind of make sense of the contradiction. You should all know this. This is one of the favorite parts of motivational interviewing. On a 1 to 10 scale, how important for you to stop drinking. And they may say, well, you know, it's only 4 out of 10. I mean, it's not that important. But instead of you saying, you idiot, why isn't it 10 out of 10? You say, well, why is it a 4 and not a 2? And then the patient has to enunciate reasons that it's a 4 and not a 2, hence convincing themselves that there is a problem. And then they have to do that. You say, well, what would it take to get you to a 6? And again, they'll have to tell you why it should be a 6 and not a 4. This is one of the most powerful techniques in motivational interviewing. You know, you can try it on a family member too. It really works. If the issue is not importance, like they know it's important to stop, but they just don't have the confidence they can, then you just do the 1 to 10 scale with confidence. So on 1 to 10, how confident are you? And then again, when they say a low number, you say, why is it a 4 and not a 2? Helping people quit is we'll ask them, have they ever done it before? Past successes, no matter how brief, will help bolster the patient's confidence. Ask them if they've known anyone who successfully quit, and they can tell you somebody, and you can say, hey, can I make a suggestion? And they say, yes. Would you be willing to talk to that person about how they did it and perhaps find somebody who can help give them support to change? Getting other people involved to keep the patient accountable, getting other people involved to help encourage and praise are key factors in tipping the balance over to increase confidence and eventually action. Another favorite question for me is, so where do you see yourself 5 years from now? So the patient says, oh, you know, I want to have a house, I want to have a family, I want to get married, I want to have kids, I want to get a good job, et cetera, et cetera. And then you go like, well, how does cocaine fit with these plans? And then suddenly that's an existential crisis for a patient because cocaine does not necessarily jive with having children and a house and, you know, marriage and a happy life. If it's a problem, it's not going to fit into their 5-year plan. And that creates a lot of cognitive dissonance. Remember, every time the patient leaves, you've got to be specific. What steps can you take between now and next time we meet that can help us decide what's best for you? So for preparation, again, always specific plans. When a person says, I just have to stop, I'm like, forget it, that's not going to work. Give me exact steps. And so here you try to get them to come up with ways that they're going to do it. You brainstorm with them, always asking permission before you give advice. And then you review the plan before the patient leaves. It has to be as concrete and as specific as possible in order for it to achieve its aims.